big welcome to Delan's family. It's very nice to see you here also. So I think the order of events is I speak for about a minute, then Delan gives his talk, and then David is going to talk for about 10 minutes as a vote of thanks. And since David is doing that, neither Delan or I need to tell any jokes, because he'll take care of all of those. So Delan is a professor of global child health, and is also the director of the UCL Centre for the Health of Women, Children and Adolescents. This is a large centre, a large interdisciplinary centre which sits within our institute, large and very vibrant. Delan was born in Sri Lanka, moved here as a child. Actually, I was born in neighbouring Pakistan and moved here as a child also. And one of the great things about the inaugurals is you get to know things about people that you didn't know. So all the migration and separation issues that we have, we've shared those with us. He then actually qualified as a paediatrician and worked with MSF, and in 2006 went to work in Pakistan, and pretty much everybody I know in Pakistan wants to actually leave Pakistan, so he actually went back and worked there, and then worked in South Sudan and Myanmar, which are all really amazing but also quite challenging places to cut your teeth. He then did a PhD in global child health with David Osrin, and then became a NIHR academic fellow, and then did a MSc in public health in LSHTM. So his work has been in quite impactful areas in global health, and that's quite, because the Institute is really, what we're really about is, I would say two things. One is doing impactful research, and the other is probably doing rigorous research. So both of those two things together. The area that Delan works in is very central to our work. So his previous work was in nutrition, migration, violence, and climate, and in all of those areas, he's continued working in those areas. But his current work, which is very close to my heart, which is very central to global health, is around race and health, race, fairness, equity, and health. And he's involved in Lancet series and Lancet Commission. This is where we go back to where we want to do impactful research, but it's got to be rigorous as well and highest quality. So he's going to talk, I've forgotten the title of your child health inequity. It's not fair, but it's kind of, he's going to tell us why he does what he does, as it were. So, Delan, thank you very much.
Thank you for turning up. I knew my children would be here because I told them, you have to be here. But it's nice that it's not only them. And it's fair to say I've been putting this off, in fact, for 3 years and a week and a day, actually. It also hasn't helped that my daughter refers to this inaugural as Papa's funeral. So I wasn't sure what to talk about, and I did what any good academic would do, and I asked ChatGPT. And very kindly, it congratulated me and told me to share my vision, passion, and scholarship. Okay. But then more helpfully, it gave a breakdown. So my journey and motivation, stuff about me, defining global health, I will give that one a miss. My research contribution, stuff I've done, and then, and I didn't prime this, but structural inequalities and racism, okay. Climate crisis, planetary health, sure. Migration, conflict, and health. And then a little bit of decolonizing health and funding, and then the future. So I'm going to talk about some of the big determinants of health, racism and migration and climate and violence and nutrition, interspersed with my career with several tangents, and then I'll end with a dystopian view of the future, after which there are some nibbles outside. It also gave me some tone tips. Be authentic and visionary, use accessible language, and acknowledge those who have supported you. And I want to start there, because this story is a collective. It's a collective with many of you, but it's a collective that starts with my family. And this, I want to say thank you to all my family. This is very much for you. And hopefully by the end, you might know what I do as well. So, my journey. The alternative title for this talk was Working Out Why I Do What I Do. And I wouldn't say I'm a proper academic. I'm not interested in any particular disease or process or methods. And what you'll see is a bit of a hodgepodge of topics and methods. But maybe the thing that links it all together is this idea of fairness. And that's something you can talk to any 5-year-old about. So I started in Manchester Medical School in the late 1990s. I didn't know what I wanted to do. I knew I didn't want to do psychiatry because both my parents are psychiatrists. Public health didn't exist. And then I ended up doing paediatrics because children are much more fun. I went for my first job in Burnley General Hospital. And I will come back to the topics of racism and violence. But I want to just give a quick anecdote. I was standing almost exactly where that photo was taken. This was the last night, our last day in Manchester, and a group of white men ran across that road and shouting the words "Packies" as they did, and attacked my friend and me. And I don't know why. I think they just wanted to fight. I don't think there was anything premeditated about it. Then, bruised and swollen, I drove up to Burnley the following day, and the British National Party had just got their first council seat in Burnley. And I drove into the sea of England flags. But it was also the World Cup, so I was very confused. I didn't know what was happening. I then wandered around the northwest and North Wales doing paediatric jobs before going to New Zealand to do neonatal intensive care. And they talk about a paper that has changed your career. And for me, it was this one by Joy Lawn and colleagues, the Neonatal Survival Series. I remember reading this, and I was amazed by the sheer magnitude, but also the methods that they were using. And I remember presenting this at a journal club meeting to a stunned audience. And the parting words from my educational supervisor were, "Go and do this stuff," which I think was also steer away from intensive care. So child mortality has always struck me. The magnitude of the numbers is incredible. And in many ways, this is a global health success story. We've seen a dramatic decrease in mortality. But I'm very much a glass half empty person. And there are still 6.2 million children and adolescents who are dying every year. Another nearly 2 million babies who are born dead. And that's incredible. That's similar to the COVID-19 mortality that we've just had. And the big inequity is that there's a massive difference between countries, almost 100-fold difference. And most of these deaths are preventable. So working with my colleague Rob Aldrich, we've tried to think about what proportion of that 6.2 million are preventable deaths. And Rob has worked with the global burden of disease data and did his magic. And for the first time, I'm showing this number that we estimate that 94% of deaths are preventable. That's astounding. 94%. And you can argue with the methods. You can say you can't compare children within a country, you can't compare countries. But I would counter that not only are they preventable, they are straightforwardly preventable. This is antibiotics and clean water and vaccines. Stop bombing children. So almost what are we doing as a society if we're not stopping preventable child deaths? This interest in mortality led into this career in global maternal child health. My colleague Jenny Hall, at the end of our PhDs, pitched the idea of running the maternal child health module, which we've been doing for the last 10 years. I countered with, shall we write a textbook on this topic to bring us fame and fortune? We are still waiting for that to happen. But with Zishan Qureshi, with Joy Lawn, with many authors from around the world, we put together that textbook. And we're now just entering the second edition with lots of new editors, lots of new chapters and plans. And many of you might be getting a tap on your shoulder soon to write chapters. So, first topic, violence. 1 billion children aged 2 to 17 experience physical, sexual, emotional violence or neglect every year. 1 in 6 children live in a conflict zone. According to the Peace Research Initiative Oslo, there has been a dramatic increase in battle-related deaths over the last few years, driven by Ethiopia's Tigray region, the Russian invasion of Ukraine, and the bombing of Gaza. But my descent into violence happened in very happy circumstances. I did the diploma in tropical medicine and hygiene in Liverpool, a very short time, but I met some of my best friends there in this time. We learnt a lot about mosquitoes and then dressed up as mosquitoes. I then worked with the humanitarian organization Médecins Sans Frontières. As Shaba was saying, my first job was in Pakistan, in Kashmir, up in the mountains, doing paediatrics. It was in that building you can see in the top left. This was an earthquake that killed maybe 80,000 people. The following job was in South Sudan in a cholera outbreak. And this was just the end of the civil war before the country had officially formed. These were clinical jobs, which I guess I found very challenging to do, to work in these situations. There's been a recent rise in tension in Kashmir, and it's been very scary, actually. This top right picture was taken in Muzaffarabad. I would go through there a lot to our hospital and pass this rocket that was pointed towards India, which I think wasn't real. I think we just used to drive past that. My third job with MSF was in Myanmar, and this was after Cyclone Nargis, massive cyclone and tsunami that killed maybe 140,000 people. My role was very different. It was training, recruiting doctors and nurses, supporting them to go out and work in the Delta region. Importantly, MSF decided that they wanted to work in mental health. So they flew in the best psychiatrists that they could find from Brazil. More importantly for me, that's how I met my wife, Sylvia. We actually met on that boat, and that was really called the Love Boat. And she's been stuck with me ever since. So my research work in violence and conflict was more focused on the longer-term impacts. We know that war is bad for child health, from direct targeting of children, collateral damage, the breakdown of societies and education and health systems. But this work looked at the longer-term intergenerational impacts, applying developmental origins ideas. And we mapped this across a number of different factors, and this has just been updated by Talia Hubble with a lot of new evidence. And as bad as war is, we're only seeing part of the picture. The consequences go on for decades, generations later. We did a small study on this topic in Sri Lanka, working with paediatricians across the country. And I mean, I wouldn't want to draw any big conclusions from the study alone, but we found quite large nutritional consequences in the adolescents later. My more recent work on violence has focused more on intimate partner violence. And this was a large project in India, Afghanistan, and Sri Lanka, working with survivors of violence, trying to develop a package of care to support their mental health. And I thought maybe the most powerful thing is just to show a few quotes from the study. This was a time when the countries were going through major challenges: the return of the Taliban in Afghanistan, an economic crisis in Sri Lanka, the COVID-19 pandemic affecting all of these countries. So I'll just give you a moment to read those quotes. So through lots of work with survivors and providers of services, through lots of theoretical work trying to understand mechanisms of action, we developed the Garima package that was led by Naireen Darawala, the Sneha team, with David Osrin and many of the collaborators you can see here at the bottom. This package has been adapted to Sri Lanka, to Afghanistan, and continues to be used. The Sneha team in particular have been training, supporting other community organizations to run this package of care. And I want to just acknowledge all the people working in this project. This kind of work is obviously very difficult to do. And it took a huge amount of effort, particularly in these challenging circumstances, to run this project. Topic 2, nutrition. So chronologically, after working with MSF, I got an academic clinical fellow post in UCL and working in public health in North London, doing service public health and health protection, and then did my PhD in UCL. My PhD was a follow-up of a randomized controlled trial of multiple micronutrients, where pregnant women were given either micronutrients or a control sample of iron and folic acid. My PhD was at bottom row, where we were following up the children later to look for any long-term impacts. So this involved finding all the children first, weighing and measuring them, asking them lots of questions, estimating their body composition, doing spirometry for their lung function. And this project really worked because of these people here. Sushil and Chaubey and Rupesh, Gagan, Derna, Chandramaya, our data collection staff, for their hard work, but also the relationships that Mira had built up across many years from that original trial that was led by David Osrin, Professor Dharma Manandar from Mira, and Anthony Costello. And here I want to acknowledge my 2 PhD supervisors. This blurry picture, I think, is the only one I have of the 3 of us. This was on the rooftop in Janakpur. I'm the one on the right, by the way. As wonderful as they are, it was always difficult to imagine being an academic. The bar seemed so high. And just when you start a PhD, you don't quite know what normal is. But slowly over the years, I came to understand that they're not normal. These are people who you can pitch almost anything to, and they will come back with something, some response. But on a serious note, there are several people who are the reason that I'm here today, and these are 2 of the most important. I would go to them with endless questions and emails and drafts and ask for advice, and I still go back to them for advice. So thank you very much to both of you. Fast forward a decade, I now have my own PhD students. My plan was always to hire a crack team of researchers to advance my own personal research agenda. They do what they want to do. So I've ended up supervising all sorts of different topics. Post-polio syndrome internationally and ethnography in Mexico, fossil fuel industry, infectious diseases, education in the UK, health systems for adolescents in Brazil, for older people in China, and migration in Nepal. So I think really I end up learning more than they do from this process. Back to nutrition. So that original trial found that there was a small increase in birth weight in the mothers who were given multiple micronutrients. This was sustained till 2 years of age, and there was a small reduction in blood pressure at 2 years of age. But by 8 years, all these differences had disappeared. There was no difference in weight and height and body composition, no difference in blood pressure or lung function. So that's fine. Our role is to see if these interventions work, and this one didn't seem to. But what interested me afterwards was the debates around this topic and the big divergence in the field. Some people were strongly advocating for multiple micronutrients. They developed cost-effectiveness tools, like you can see here. Others were strongly advocating against micronutrients, saying you shouldn't do this kind of intervention. My role was focused on these long-term impacts. Was there any benefit in childhood later on? So I managed to pull together a team of nutrition superstars from UCL, from Delhi, from Southampton, and we did a meta-analysis to look and see whether there were any beneficial outcomes. And really, we didn't find any. There was no survival advantage, no improvements in growth, no improvements in functional outcomes. And this work led into the World Health Organization guidelines. But this debate is still very active today. There's still lots of disagreements on this topic. Topic 3, climate change and air pollution. According to Lancet Countdown, climate change is the biggest threat to global health of the 21st century. My research really began with air pollution. When I became an academic clinical fellow, I came to UCL, and Anthony Costello, who was the head of department at the time, called me into his office and said, "Do you want to go to Nepal and collect some air?" I said yes, and then left the room and wasn't sure what I was doing. But I went there, worked with the MIRA team, worked with Naomi Saville, who was based there, and we did initially a small project on endotoxin levels, which is from the burning of biomass fuels, that's animal dung, wood, straw. We then did a much larger project, advised by John Ayres, Sean Semple, and Kermi, to estimate air pollution exposure amongst children. So in this project, we did about 3,000 hours of air pollution sampling to estimate what their exposure was. And we found that it was indeed very high. It's 168 micrograms per meter cubed. And to put that in context, that's about 11 times the World Health Organization upper limit. I've included a graph because I think inaugural lectures have graphs. So I put this one in. This is a real-time kitchen sample from burning of one of these biomass fuels. And you can see these peak levels are reaching 60. But if you look very carefully, this is 60 milligrams per meter cubed. This is 60,000 micrograms per meter cubed. These kitchens were so incredibly smoky when you go into them. And we did a public engagement project after this to try to help to reduce air pollution levels. And really the women in the project took matters into their own hands and started to reduce their own air pollution levels. Later work has focused more on climate change and the Envisioning Environmental Equity project. In this project, we spoke to minoritized communities from across the world who are really at the front line of climate change to talk about the issues that they're facing. We reviewed the literature on this topic and found that racially minoritized groups, migrants, indigenous communities are more vulnerable to climate-related impacts. If we look at this figure on the right, the top map shows who's producing carbon dioxide, and this is very much the rich countries of the global north, which make up 14% of the world's population. But where are the health impacts? They fall on Latin America, on Africa, or on Asia. And I thought maybe the best thing to do would just to show you a couple of minutes from some of our participants. So this project was conducted in Brazil, Uganda, the Philippines, and Sri Lanka. And I'll just show you a couple of minutes of them talking about their issues.
Tá muito quente agora. Quando tinha mata aí era bem refrigerado, né? Por isso que eu planto muita planta assim. É por isso, para casa do calor, né? Mesmo assim dá muito calor.
Parang hindi ko ma-imagine yung panahon ng klima ngayon. Parang sabi ko, Malapit na yata tayo sa MPS.
Badde gatusumbuyira ddala nnyo naye oluvannyuma olw'akasasiro atubeeramu ate nga olusi kesisi eremerera okutuuka mu bitundu byaffe okutumugyamu.
Tá havendo muito assim, febre, pessoas que criam seus bebezinhos sofrem com negócio de falta de ar, diarreia, muitas das vezes vômito.
Tulina obuzibu obw'amazzi gano bw'omulaba ng'omwala guno okuba nga giyita mu nzija zaffe ng'ate tegirina wala wagigina yita ne tufuna obuzibu gituviiriddeko obulwadde olw'abaana baffe abalwadde ebirwadde ng'ebiddukano bakyala baffe kubanga gye bagenda kati nga bulaba ekiiko.
A questão da saúde na comunidade, ela é pouco precária. Primeiro começa porque nós não temos um posto de saúde, que é o básico. Nós não temos um medicamento básico, nós temos um ACS na comunidade que faz o mínimo da tarefa de um ACS. E o atendimento em si na saúde, quando alguém adoece, somos nós.
So, thank you to the many people in this project, and there are a lot more films that you can look at after if you'd like to. The second version of this project is trying to develop more local solutions to try and improve their health. I also want to mention the team, the EEE team. I realised that working with friends produces actually better results, and this team has been wonderful. Our partners in Brazil, Uganda, Philippines, and many people here from Sri Lanka. And this project is finishing soon, but all these people are planning to carry on meeting anyway afterwards. So, topic 4, migration. Migration is one of the defining issues of our time and a profound determinant of health and really a political hotcake that it's fair game to openly demonize migrants. Ibrahim Abubakar had since taken over as the director of the Institute for Global Health, and after my PhD I got an academic clinical lecturer post with Ibrahim. And Ibrahim's really another person I really want to thank and acknowledge as one of the key reasons I'm here today. So Ibrahim called me into that same office that Anthony had and asked me if I'd like to be part of a Lancet commission on migration and health. I said yes, and then I left the room and I thought, I don't really know what a Lancet commission is. But anyway, after several thousand hours of work, I knew what a Lancet commission is. But I got to work very closely with Ibrahim, with Rob, Miriam Orchard, Rachel Burns, and 20 experts from around the world to produce this commission report. And we did lots of new analyses, we summarized the evidence, but one thing we overtly tried to do was to challenge the myths around migration using the evidence that we had. And for me, this was a huge learning experience, thinking about these political determinants of health, thinking how they relate to what we see in terms of individual people, and then potentially ways that we can help to counter that. Around the same time, I did a qualitative project talking to adolescents in Lebanon. In terms of forced migration, the numbers have increased quite dramatically from 38 million in 2011 to 123 million last year. This study was conducted in 2019 when around 1.5 million people had moved across the border from Syria to Lebanon. And this project, this picture is actually from an informal settlement camp. This was the outside of a school in that camp, very close to the Syrian border in the Bekaa Valley. But we spoke to these adolescents and we talked about the issues that they're facing. And some of the main issues were around mobility, around finances, around violence, but it also affected different groups differently. The adolescents with disabilities had a huge number of restrictions about what they could do. Girls faced issues around social expectations and being allowed to go outside. Boys, especially the Syrian boys, faced harassment at checkpoints, police and military checkpoints. But the other thing we learned is that while they were physically very restricted, digitally they were all connected. They were all in touch with each other through their phones and media, and in touch with all their friends who'd left the country as well. We then tried to think about migration in its entirety, and we did this study linked to our commission, looking at children who are left behind when parents move, mostly for labour migration. The numbers are very uncertain, but in China alone there's around 60 million such children and adolescents. And contrary to our expectations, because these children are getting the remittances, their families are getting remittances, so are better off. But we found a higher risk of depression, anxiety, malnutrition in these children. We then did a number of other studies looking at different groups, undocumented migrant children, unaccompanied migrants, child health policies towards migrants in Europe. And the thing that links all of them together are that there are these health system failures that are due to discriminatory policies that limit appropriate access to care. And these policies lead to language barriers, cultural barriers, children taking a longer time to get diagnostic results, reduced diagnostic efforts in general, which in turn links back to often authoritarian, right-wing populist governments that lead to the anti-migrant sentiment that results in these children becoming unwell. My own very small example of this was taking my son for allergy testing in North London. We had under the hostile environment in the UK, we had a charging policy for migrants for secondary care that includes children. So I took him for allergy testing, and then a little while later I received a letter asking if I should pay, which I thought was very unusual because unusually I know the rules. And I couldn't work out why we got that letter. He's a British citizen, we are all British citizens, and I think it's only because our names sound a bit foreign. I think that's the only reason we got this. So this work led to my midlife crisis, and honestly it's not just midlife. But the question I asked myself is, does this matter? What we're doing, does it matter? And I'm still here, so I think it does. But my conclusion was that we have to do things differently. We can't just rely on producing a research output and by osmosis it goes out to an eagerly awaiting public. So we've done lots of different projects. This is an art project on air pollution, comics on climate change, films on child marriage, a narrative story on female infanticide. We've done other climate cafes in Uganda, an online game on violence in Sri Lanka, theatre work in Brazil. And this idea also led to forming the Race and Health Group. And the idea behind this is to take these research outputs to look outwards in terms of education, engagement, advocacy. And I want to mention three people. A lot of people have been involved with race and health, but three people in particular. Sujitha Salvaraja, who founded this group with me and produced this very wonderful website. And then Meeta Hawke and Sonora English, who've really taken it forward and done a lot of the background work around these outputs that you can see. This idea also led to my other podcast on global health. There are two things I really like. One is podcasts and the other is biographies. And this was a perfect marriage between the two. But over the years, I got to speak to lots of super interesting people talking about their work, but also their lives, and hopefully translating some of this out into the world. Topic 5, racism. So racism began in 2020 with the Black Lives Matter movement. But more seriously, that certainly did increase conversations around racism. And the COVID-19 pandemic as well, which saw ostracization of people at borders, the targeting of East Asian people, differential mortality, we see in the UK, Bangladeshi people have between a 4 times and 5 times higher mortality compared to white people in the UK. But while it's easy to blame one policeman in Minneapolis, racism happens everywhere and always has done. And it's down to the deeply rooted systems of oppression that result in harm to people. And when I talk about racism, I can be quite abstract. And I like to ask this question, what is racism? Because it means something very personal to people. And for me, it's about my family. So my parents and I came to the UK in 1981 when I was still a budding footballer. Then my mother and I returned to Sri Lanka and then came back here in March 1983. 4 months later, the civil war began in Sri Lanka with the anti-Tamil pogroms. We were lucky that we had just left the country at the time, but many people weren't so lucky. A few years prior to that, my parents were subjected to a targeted attack where a mob went to their house and burnt it down on the basis of my father's Tamil ethnicity. They were lucky, they weren't in the house and they survived. But lots of people are not so lucky. So why do I care about racism? Racism is the story of my family, it's the story of many families. And my parents were lucky, I was incredibly lucky. They sheltered, protected me, and I'm here speaking to you in this grand setting. But lots of people are not so lucky. And to those who talk about the island of strangers that we're living in, where it's okay to demonize migrants, well, I'm one of them. My parents are, my wife is, I guess many of you are. And this language has real consequences. So the work on migration, the Lancet series, we tried to do lots of different things. We tried to summarize the evidence around migration. We looked at the political implications. We looked at the history, definitions, mapped the health system. And in the second paper, looked at the health consequences across every life stage through these behavioral, psychological, physiological mechanisms. And you can see the effects right from birth. In the UK, black infants have a 3 times higher mortality compared to white infants. Asian infants have double the mortality compared to white infants. And it shouldn't be like this. There's no biological difference between racial or ethnic groups. These differences and the many outcomes that we see are down to interpersonal and structural racism. The work on the Lancet series led on to the new Lancet Commission on Racism and Child Health, very ably led by Abby, Sonora, Lou, and Mita. And I'd also like to thank our editors here, Pam and Richard, of course for your guidance and support, but actually on a slightly high level. It's very easy to not cover topics like racism and migration. And to do that in a high-profile way is really a big thing. My plan to continue working with friends has continued here, and we've done an awful lot of work, but it's been fun along the way, just working with all of these people. In addition to trying to map the health outcomes related to racism, we looked at the interventions, and we tried to map all the interventions across this conceptual model. We developed these 6 key principles of action around decolonization, intersectionality, diversity and inclusion, reparative, transformative justice, active anti-racism, and a human rights-based approach. But in many ways, this work was kind of unsatisfactory. Most of the interventions tended to be at that individual level, didn't work very well. The structural interventions worked better, but were rarer, and even they weren't perfect. So in a sneak preview of our new work, we've tried to delve into that conceptual model, to pull it apart, to look at the mechanisms of action. How are these factors related to each other? How do they result in the outcomes that we see? how do the interventions work? Who do they work for? Why do they work in some circumstances, and why don't they work? And then we went a bit crazy and tried to map racism as a system, try to understand all the many interactions between all the factors, from the structural level to that individual child you might see in front of you. And by doing this, you can also come to understand why interventions often don't work, because nothing exists in isolation. And this has broader implications for public health. You need to understand the system that you're working with to try to understand how these interventions work and what combinations of interventions you need across levels. I warn you that Lou Graham will be testing you on this model afterwards. So a shift to the next 5 years, and most of that is going to be taken up by this new large project, the Maternity Disparities Consortium. And my work is largely split into 2 areas. First on preconception, working with colleagues here, and many of the people listed here. And really, for me, this is a new topic, so trying to understand more about preconception care. And the plan is to try to improve the care before pregnancy and between pregnancies. The other aspect of the work is working on racism and intersectionality, where, along with Michelle Fisher and Myreed Black, I'm co-leading that theme of work, where we can try to put some of these theoretical considerations into practice to reduce these disparities in the UK. So, I said I would end with a dystopian view of the future. And over the last 80 years, since the end of the World War, we've been living in increasingly peaceful times. But the question is, are we at an inflection point now? It may be that I'm wrong, but we are seeing a lot of these things happening now. Violence is at an all-time high since the end of the Cold War, with consequent increases in mass forced migration. Climate change is happening and will increase. There will be another infectious disease epidemic, and fueled by the spectre of antimicrobial resistance could be worse. It's possible that artificial intelligence will come in and will fix all these problems. But when the lefty liberals, Sam Altman and Elon Musk, warn about the dangers of artificial intelligence, I do get worried. But one thing I'm more certain about is that not all children will be affected equally. The most disadvantaged children will have the worst outcomes. And maybe I'm wrong, and maybe the younger members of the audience will think back to this lecture and say, he was an idiot. So I want to end with something a little more positive. While doing this lecture, I've been thinking about this question. If you could do one thing to reduce child health inequities, what would it be? And I've pitched that to many of you, and I've had about 100 responses. And they broadly split into 3 categories. The first category focuses very much on the individual children. It's about looking after, caring, supporting, hugging children. And there were some lovely responses, convincing every child that they're worthy of love and care, looking after other people's children like your own, keeping children safe and allowing them to dream and accomplish their dreams. The next set of responses was more on the health system. Lots and lots of responses to improve the quality of care, to improve access to services, to improve support for mothers, and contrary to what is happening internationally, to increase reproductive choices. Some responses on increasing funding, improving data systems. And then finally at that structural level, and by far and away the highest number of responses was reducing, ending child poverty. And there were some very specific things like benefits and taxation, and some that were much more radical to change the entire economic system. There were lots of responses around school and education, including from children, and then to stop killing children in wars, and surely that's the most basic thing we can do. And then finally, responses around increasing voice and supporting children and political representation. So after doing this, it felt entirely inadequate to just ask for all these responses and produce 3 slides. So what I thought was, it strikes me that child health inequity is often invisible. And I wondered if I can try to make it a little more visible. The only creative thing I can do is origami. And after enlisting a certain amount of child labor, we produced a crane for every response that I received. And you can see these cranes outside, and please do add to them if you wish. In terms of child health, this relates to the story of Sadako Sasaki. Sadako was 2 years old when an atomic bomb was dropped on Hiroshima. Sadako survived, but 10 years later, she started to feel dizzy and was taken to hospital, where she was diagnosed with leukemia. The doctors called it the A-bomb disease. There's a tradition in Japan to fold 1,000 cranes, and Sadako started doing that, but then sadly died later that year. But her friends continued to make cranes. They made a monument to her, and children still send cranes to that monument. So I wondered if we could make cranes as a symbol. And I've been speaking to colleagues in Great Ormond Street Hospital, and we're hoping to create something, to put something there with these cranes that can be interactive, where children can add to this to talk about the issues that they're facing. And this can be some kind of symbol towards child health inequities. The actions taken by leaders have real consequences, be they the ending of the 2-child benefit cap, arms trade to other countries, the backtracking on fossil fuel industry reforms. And each action adds a crane to that chain. So I want to end with a quote from my colleague Jaime Miranda. Como un niño, be like a child. The idea of fairness comes naturally to children, but as we grow older, we wrap it up, we layer this in complex arguments. It's only fair that we exclude and persecute those people because they look different. But maybe we should be more like a child. Maybe we should listen to children, and other than forcing them to come to inaugural lectures, maybe we should give them the power to decide. So I'm sure that there are lots of people I should have mentioned who I didn't. So if I've ever authored something with you, you're somewhere in the sea here. And if I haven't, you'll be on the other side of the globe. Thank you very much.
Specs off, specs on. I think we should have another clap for that. So, friends, good evening. My name's David Osrin. Younger versions of me feature in some of those slides. At this point in this kind of event, it's usual for an elderly, largely unintelligible academic to say a few words. Delan made the big mistake of asking me to do it after his extraordinary lecture. So I'll go on no longer than 50 minutes. This lecture is supposed to mark his transition to being himself a largely unintelligible academic. I believe that Delan actually became a professor in 2022, And this is really a hallmark of how meticulous he is, that he's taken this time to make his presentation perfect. We're so pleased that so many of you are here today. Sabri, you are a bit bigger than in this photo. You've really grown quite a lot, and if you look at that carefully, you can see that both of you are wearing matchy hats. And I didn't realize this until today, but if you look at these photos, you see quite a lot of hats. And this afternoon I saw some mosquito-related headwear as well. So keep your eye out for the hats. I want, on behalf of all of us, to welcome Delan's closest family, Sylvia, Sabri, Maya, Delan's parents, Deva and Dolly, Delan's brother, Shiran, with Rachel and Sophia, and Delan's aunt, Bilkish, and all of you, many of you who I haven't seen for a very long time. So I'm going to tell you two stories. I think I first met Delan in the early 2000s. So there was this guy, and he was something called an academic clinical fellow, and everyone said he was really clever. And he was a doctor who was doing his public health training. He'd worked in a number of different challenging environments, including Sri Lanka, but he'd also worked after the tragedy of the tsunami, and he really wanted to do something to help the world. And rather foolishly, he really wanted to do a PhD. And my first story is that back in the early 2000s, I'd be sitting in an office and I'd see this figure outside the window, kind of loitering, wanting to come in and discuss something. And he would come in holding a pad of paper with a very intense expression, a pad of paper a little bit like this. And he would say, "Could I just run something by you? Should we maybe look at the effects of exposure to sunlight and vitamin D on women and children?" And we discuss it for some time. I think I would usually make non-committal noises, interesting, which my colleagues in India always say in English means, I don't think it's interesting. And sometimes later, I was asking Delan about this a couple of days ago, and I remember it being sort of weeks or months, and he does too. I'd be sitting in my office, and I'd see this figure through the glass, kind of hovering there, kind of loitering, and I'd open the door and he'd say, "Could I just run something by you?" I'm thinking of doing a trial where we wrap newborn babies in space-age cling film to make them better. And here I want to introduce something about Delan that I think many of you will resonate with. He would have this pad of paper, and it would have a series of bullet points on it with numbers. And you could always see that there were quite a lot of numbers and quite a lot of bullet points. And he would never hurry. He was always calm and quiet and measured. And I'm replicating that behavior right now for your benefit. But he was meticulous. And you knew that it was a good idea, as you will all know, to let him work his way to the end of the bullet point list. And one day, after he'd had another idea, and we discussed it, I kind of said, "Look, I know you want to change the world, but there are these kids in Nepal, in the south of Nepal, they were born during a trial, now they're growing up. I know it's not quantum justice, I know it's not saving the world, but would you like to go and spend some time in Nepal and follow them up?" And one day he just said yes. So the second story is about how Delan is the great collaborator. He always finds out who's doing the most interesting work. He contacts them, he goes to meet them, and then they join the family. And I've got this hazy memory that's not confirmed by Delan, that when he was doing his PhD, after he'd already got Jonathan Wells, myself, Tony Costello, Dharma Manandar supervising him, he met John Ayres, he met Janet Stocks, and the university said, look, there is a limit to how many supervisors you can have. He says he doesn't remember that story. Delan's always finding people and listening to them and helping them. And lots of people in this room. And I think there are people online. I think that you'll resonate with that and know that it's true. But strangely, despite all the seriousness, they always seem to be having a good time in a restaurant or at the seaside. I was told today that there is a photo of Ibrahim Abubakar smiling, but I haven't seen that photo, and Ibrahim isn't here. Nobody sent it to me. So Delan's a person who is both brave and creative, and when he gets the idea of working on something, he just does it. He doesn't try to work out what will most likely be funded. He works out what we need in the world. And this is something that I admire greatly, and I'm sure that many of you do too. The other thing is that when he finds out about something, he learns about it and he does it. He's done lots of projects that work, as you've seen, with art. He's tried to develop new theories around racism and health. He's made complicated mathematical models, thanks Lou. He's made movies, which we saw a bit of one. So when we were I'm getting a bit stuck with my slides. When we were getting ready for this event, I thought it would be nice to contact all the people Delan has worked with in the last decade or so. So much like he began, I used ChatGPT. It didn't work very well. And then I spent a weekend manually searching all of his publications. And there were 168 people on the provisional spreadsheet list. And I thought, well, he doesn't really know all of them. So we discussed it, and he said that some of them he didn't know that well because they'd come out of follow-on work for Lancet series and so forth. But eventually, I really cut the list down, and I got the list down to about 100. And I wrote to them, and most of them wrote back, and some of you in the room. Lots of people send photos, which you're now looking at. And I wanted to do something a little bit technologically complicated that I think will work. At the beginning of Delan's podcast, Global Health Lives, it goes like this.
Describe yourself in 3 words.
Academic, practitioner, and activist.
Describe yourself in 3 words.
Adaptable, optimistic, and connected.
Describe yourself in 3 words.
So
Can you describe yourself in 3 words?
The last one was a little bit different.
passion and determination.
Now I have to do something with 3 fingers. Oh, help, Delan. No, I'm doing it with 4 fingers. Oh, yes, brilliant. Thank you so much. And because he did that, we thought we'd turn the table. So I asked all the people to describe Delan in 3 words. And here are all the words in alphabetical order, but not repeated by frequency. And here are the top 6 words that got more mentioned than others, highlighted there. So this is Professor Delan Devakumar. And this is Professor Delan Devakumar. We love you, Delan. Put your hands together. I think we go outside and do origami now. Thank you all for coming. Another hand for Delan.